Hi, everyone. We are going to get started here in just a minute. I believe we have quite a few attendees. So by way of introduction, I would just like to lead us off by welcoming everybody to our session. We're here to talk about physician compensation models. Specifically, we'll be looking at alignment, performance, and longevity and investments. I'll start out by first introducing myself and my colleague who is with me as well, Erin, Dine. My name is DeGrande, and I am an attorney at McGuireWoods, LLP. I work in this particular context in quite a few different ways. I've done a lot of work with physician groups, both large and small, dealing with employment agreements with physicians from both perspectives. I've also done quite a bit of work working with surgery centers, and other assorted types of providers such as health systems. So I will also let my colleague here, Erin, introduce herself and talk a little bit about herself before we get started.
Welcome, everyone. My name is Erin Dine. I am an attorney in the healthcare department at McGuireWoods with Chris. I, like Chris, work a lot with small and large physician groups, but also primarily focus with our client, the private equity fund clients, who are investing in physician practices. Every transaction and every day I seem to be dealing with employment issues, especially in the context of physician employment agreements or any kind of other arrangement involving physicians. So we're excited to present today, and I'll let Chris discuss what we're going to discuss.
So first off, as Erin and I both already mentioned, we are employees here of McGuireWoods, LLP. And first, we'll take a look at what we are going to discuss here in this session. We will be touching on three main types of areas and three main points. First, we're going to take a look at our common compensation models. This will range everything from your most basic of straight salary arrangements to some of the more complex arrangements such as equity and group revenue sharing or capitation compensation models. We'll then focus on the types of relationships that you might run into between physician practices and physicians, running from employment agreements to concierge medicine type of arrangements. Then we'll finish off by keeping an eye or noting some things that could come up in a physician compensation arrangement that are just kind of extra things to watch out for. As another note, we will be saving some time at the end for questions, so that if you do have some questions, make sure to write them down and we will be able to answer them at the end. So we're first going to kick things off by taking a look at the different types of common compensation models. The first of which, as I mentioned, is the straight salary compensation model. This is one that is not exactly unique to the healthcare or physician practice environment. This is what you would probably hear commonly referred to as the W-2 employee relationship. Salary in this situation is set in advance. Both the employer and the employee know exactly the amount that the physician will earn. It'll be set out in an agreement, and for the most part, not really subject to change over a certain period of time. Some of the benefits of this arrangement are that it provides generally a sense of security. Again, both the employer and the employee know exactly what they're getting. For an employer, you can set your cost expectations. For an employee, you know what exactly you're getting in your salary. This is particularly useful and probably more prominent when dealing with physicians who are younger or first starting out as physicians in order to give them a sense of security. As you can imagine, one of the drawbacks of this is that this does not provide a lot of incentive for increased production. If an employee knows exactly what they're getting, they will do what it takes to get just that. Again, most often you'd see this in the situations that involve large HMOs, academic medical centers, or large corporate or physician-owned practices. We've included here a graphic that we think kind of helps put some perspective to this straight salary compensation arrangement. For example, as you'll see here on this chart, quite a few physicians, when asked what percentage of their income comes from sources other than guaranteed salary, answer that actually none of their salary does. So, as you can see here, there are still some that have different types of compensation models that have income that comes from areas other than salary. What we're looking at in this next slide is the physician answer to how much of a physician's compensation is tied specifically to productivity as opposed to salaries. Again, you'll notice that it is not entirely surprising that those physicians who are practice owners or partners have kind of a larger percentage of their compensation linked to productivity. But you also see that physicians owned by hospitals and large health systems often might have these kind of arrangements as well. This leads us to our second type of compensation arrangement that I'll be discussing, which is the concept of a straight salary arrangement with a bonus or incentive type compensation built in. Similar to the prior arrangement that was described, your base salary will be set in advance, but included in this is a component that rewards increased production. So these arrangements might award extra bonuses for multiple different types of metrics. We've listed a couple here. Common ones would be extra hours that are worked, extra coverage for call hours. A popular one would be a percentage of total collections or a percentage of collections once a certain threshold amount is hit. You can think of this as if a physician brings in collections over a certain number, like $300,000 in collections, they then get a percentage of the collections over that amount. Also, another common metric to put into these bonus incentives would be supervision of mid-level providers, things like nurse practitioners, physician assistants, and also the performance of administrative duties, things like performing medical director or clinical supervision type arrangements. Again, this gives you the sense of security for a physician. It also gives the physician a little bit of incentive to produce, which you can see as a benefit for the employer. Again, though, the risk is still largely on the employer in this situation. This typically isn't really a strong encourager of entrepreneurship. Even though you are getting your salary and incentivized to meet productivity bonuses, there isn't a whole lot of incentive to kind of reinvent the wheel in your work environment. So with that being said, I'm now going to hand it over to Erin to talk to you about a couple of other compensation models here with physician practices.
Yes. So the next compensation model that's on the slide is the production or productivity-based compensation model. So in the 1990s, I'm sure everyone is aware of the wave of physician employment that occurred, particularly by hospitals and large health systems. However, during this time, the employment model failed, mainly due to guaranteed compensation models, as well as the lack of expertise in physician practice management. During this time, the productivity of physicians dropped with this guaranteed compensation model. However, almost 30 years later, the employment of physicians has heightened, but guaranteed compensation models are not as prevalent. We're not seeing them as much right now. Instead, we are seeing compensation based on some type of productivity-based compensation, whether it's based on work relative value units, which we refer to as work RVUs, gross charges, net charges, or net revenues. One of the main advantages of a productivity-based model is that physicians are rewarded for extra effort, and they're encouraged to be mindful of excessive overhead costs. Although production is incentivized in this model, competition amongst physicians within a group is also heightened. Further, as the wave of private equity investment in physician practices continues, we are also seeing a lot of employment agreements in this area with some form of production or productivity-based compensation. When investors are looking for potential partners, investors are placing a high value on a practice's reputation, brand, as well as a high value on its anchor physicians. That being said, by placing such a high value on these factors, investors are expecting that the anchor physicians of a target practice will remain part of the practice for multiple years, and therefore are looking to incentivize those physicians to be partners through unique and innovative compensation models within what we call the MSO-PC business model. And so one way to increase the longevity of a physician is to ensure the physician has skin in the game even after a sale, is to construct a compensation based on a percentage of the collections personally performed and provided by the physician. This next slide discusses the intersection between value-based care and percentage-based compensation. You'll see the figure on this slide demonstrates the change in compensation plans as a practice starts to value value-based reimbursement and as this reimbursement increases. As everyone knows, the healthcare industry is gradually experiencing this shift from volume-based reimbursement to value-based reimbursement, and so that shift has also implicated physician compensation models in order to align with that initiative. With healthcare organizations across the country, a 5% bonus for physicians will likely not sufficiently drive a change in physician behavior. However, a reward at least 25% of a physician's compensation or more would likely motivate physicians to engage in value-based care behaviors, and you're seeing that with this model on this slide. The next slide we talk about is equity and group revenue sharing model. The key strategy for physician alignment for the past 10 to 15 years has been to acquire and employ physicians to ensure that services provided by these physicians or practices remain within the group or the system and are not acquired by a competitor. And so the primary concern has been keeping the physician productive, and that becomes the basis of this compensation plan and model. An equity group revenue sharing compensation model is a simple model to administer and divides the profit of a practice amongst the group's physicians. This model and method is most common in smaller medical groups or specialty practices, and it's important to ensure that this revenue is divided in a way that complies with state and federal healthcare laws and does not reward the volume or value of referrals. This model incentivizes a team approach and the overall growth of the practice. However, it can be difficult to implement if varying levels of experience exist among the physician group members. And also, we've seen conflict created when there's a perception that one or more of the group members are underproducing by the overproducing group members. In addition, after private equity investment, selling physicians may be offered rollover equity in either the private equity fund or a holding company or the management company, which can offer opportunities for compensation after a sale, especially within an MSO-PC model. However, healthcare regulatory issues do exist when that happens, so it is good to consult a healthcare attorney. The next slide discusses an innovative compensation model called the earnings before physician pool, which is we refer to as the EBPC pool that we're seeing more and more, at least at the LOI stage at this point, and then also in transactions that have closed. But this model is a way for practices to establish alignment and longevity, specifically after a private equity investment, so that certain employed physicians can be compensated in accordance with earnings within this pool. This compensation model offers a significant amount of flexibility in establishing the strategy, but most groups typically set the pool to equate to about 60 to 80% of the net practice earnings after deducting certain expenses and losses before physician compensation, excluding net practice earnings from pathology, other ancillary services, prescription drugs, and other designated health services. The EBPC pool is also only effective in achieving alignment and longevity amongst the anchor and brand physicians when there is an internal hierarchy amongst those physicians when splitting the EBPC pool. And this could largely depend on the physician's experience and leadership within the group. Ultimately, by establishing this model, stakeholder physicians are incentivized to grow the pool through add-on acquisitions and physician recruitment efforts. However, this pool may reduce the total purchase price amount, but with specific physician targets, this pool is an attractive offer because it has qualities that could include faster income repair, physician autonomy, and incentives to make the pool larger through add-on acquisitions and other growth mechanisms for the practice. However, this model is still in its infancy, and it's heavily dependent on state law and specific nuances contained in federal fraud and abuse statutes. Therefore, intense scrutiny and care are necessary when structuring these models, and we're happy to help if this is a model for you. The next model is capitation, and the concept of capitation became prevalent in the 1980s and early 1990s, and is still present in certain HMO-intensive markets such as California and the Northeast. Capitation is a type of healthcare payment system where the doctor, physician group, or hospital is paid a fixed amount per patient for a prescribed period of time by an insurer for specific services. And so the rates for capitation payments are developed using various different characteristics, using local costs, average utilization of services, and the capitation payments can vary from region to region of the country. Many plans establish risk pools as a percentage of the capitation payment, and then money in this risk pool is withheld from the physician until the end of the fiscal year. Translated into a compensation model, capitation involves distribution of health plan payments among physicians in a nearly equal manner or based on some type of formula. This model essentially allocates the risk of managing patients to the providers and forces the providers to manage the cost of healthcare as a way to get high quality, low costing, and efficient healthcare. Because global capitation contracts may entail providing all services to a large group of patients, a high percentage of catastrophic diagnoses may negatively affect a group's or hospital's bottom line and therefore individual physicians' income levels, but we are seeing this model prevalent in certain areas of the country. Turning next to Chris, who will discuss the different types of relationships between practices and physicians.
Thanks, Erin. So we'll again discuss a varying amount, or the different types of arrangements that one might see between a physician practice and a physician. Starting out again with the most basic of ones that you would expect to see, which is the employment relationship between a physician practice and a physician as an employee. As you might expect, this employment relationship would be documented via an employment agreement between the practice and the employee physician. The practice then ends up providing the physician with all of the typical things you would expect an employer to provide to an employee outside of a healthcare environment. Things like PTO, malpractice coverage, and then their compensation. Things that are a little bit on the, I guess if you want to call them, the risk side. An employer has to be aware of the risk of a vicarious liability when you are dealing with an employee, meaning that you as an employer can be held liable for the actions of your employee. It's also an important thing to make sure that you consult with an attorney with regard to taxes and withholdings and employee benefits when structuring these type of relationships. These are just items that can easily go wrong in an employment agreement and should be run by an attorney. Again, these employment agreements will typically include non-compete and exclusivity provisions in the employment agreement. This is another item that should definitely be run by employment counsel, just to make sure that you are not in violation of any state laws or regulations with regards to non-competition, non-solicitation, confidentiality provisions that are in an employment agreement. And again, we talked about quite a few compensation models just a little bit ago. The compensation model can pretty much vary, and it can incorporate multiple aspects of those models that we just spoke of. Typically, though, you will see an arrangement that includes fixed compensation with an added bonus or productivity-driven. An employment agreement does allow an employer to give the idea of equity consideration. For example, it may not be that the employment agreement specifically promises equity, but it may also offer the employee the benefit that they will be considered for equity consideration and to be made a partner in the practice at some point down the road. If there are federal dollars that are at issue, anything that has to do with Medicare, Medicaid, or any other federal payer program, compliance with the Stark Law and anti-kickback statute is necessary. However, typically when you're in this realm of an employment agreement, it's typically easier to accomplish compliance with these laws. I'm going to actually let Erin speak on our next type of relationship, which is independent contractor relationships.
Great. So most practices that want to avoid all of the risks that Chris just mentioned with regard to employment arrangements consider the option of engaging a physician as an independent contractor. So sometimes physicians are offered this option of becoming a contractor rather than an employee or a partner of a practice. That means as an independent contractor, you sell your services to the practice, but you have no legal connection to the practice other than as a provider of services. These contractors are also referred to as freelancers or 1099 employees in some industries. Independent contractors usually have more freedom and flexibility, but independent contractors do not have insurance and other benefits provided by the practice. An example in this case is that we recently worked with a private equity fund that invested in a dermatology practice, and the practice was a large practice and had a lot of dermatologists, but also contracted with providers that are not dermatologists, such as podiatrists, family care practitioners, and other certain providers that just did not make sense in their employment context, but they were contracted as independent contractors and had the flexibility to come and go and really have their own control over their own practice, and that worked for that practice specifically. However, practices with independent contractors must be careful not to blur the distinction between an employee and an independent contractor. Maintaining this distinction and reducing the control over an independent contractor is very important for tax reasons and to mitigate the risk of vicarious liability. Therefore, if you have an independent contractor agreement, it is important to consult with a labor and employment attorney or a healthcare attorney to ensure that those controls are not incorporated in the contractor agreement, to ensure that the risks with an employment arrangement are not encapsulated into your agreement with the contractor. If a physician is paid, however, as an independent contractor instead of an employee, there are more stringent requirements in connection with federal and sometimes state fraud and abuse statutes. For example, the independent contractor arrangement typically needs to fit within the personal services or fair market value exception to the Stark Law if DHS is incorporated in the arrangement and if there are DHS referrals, which these exceptions do have more stringent requirements, such as the agreement must be set in advance and cannot be changed within 1 year. Another arrangement that is an alternative to an employment arrangement is a professional services arrangement. So that we see this arrangement typically when practices do not want to employ or contract with an individual physician, but rather want to enter into an arrangement with likely a smaller group of physicians or a physician group to provide a certain service or a specific service line in exchange for a compensation rate or model. Typically, this model is implemented when the employment or contractor relationship just does not meet the needs of either party. But this PSA allows physician practices to remain intact and allows this unique alignment opportunity to ensure autonomy within the physician group, but also to start a relationship with a larger system or group practice between the physicians, and it may cause the groups to consider an acquisition in the future. But this is a way to kind of test the water to see if a fit works within the groups. Services provided within PSAs typically include a specific service line, as mentioned, which could be anesthesia, consulting, or any other service line. These arrangements also incorporate more stringent requirements if compliance with the Stark Law or the anti-kickback statute is required in this context. So consulting an attorney for these arrangements is likely recommended.
So the final type of arrangement we will discuss here is a new model that's kind of becoming more popular and that you might have seen around a little bit more, which is the concierge medicine model. This is, in short, is a business model whereby a patient will pay a physician a flat membership fee in advance for provision of medical services. These fees can range. There's about an average of about $150 monthly fee. The benefits to patients are that they get improved access and availability of physicians and care. So for example, items that we've seen, a patient may have the ability to contact their provider on a more easy basis. For example, the ability to email or get in touch by phone call with their provider, much easier than they would be otherwise. They might also have the ability to book next day appointments as opposed to having to schedule an appointment a long time in advance. And then there might also be certain services that are just covered in their concierge fee that things that would be included in this might be your yearly physical on top of some other kind of minor lab work that might be covered in these fees. The benefits for a physician, they're basically cutting down on their amount of patients that they need to see in exchange for this retainer fee. So a practice can also have the benefit of becoming sort of a hybrid. It could be 100% concierge patients. It could also mix its concierge in. Again, and one of the main benefits is the physician's ability to see or to have less patients under their care and thereby see less patients in a single day. This improves the personalization of the care between the physician, not just because the patient is able to contact the physician easier, but also just because there are less people and less patients for the physician to worry about. And one of the main benefits that physicians have expressed about this is it can just help reduce physician burnout so that they don't feel like they are just running through the wheel of churning out as many patients as possible in a day. And you can see here on the graphic that we've attached here, which describes physician compensation in general, concierge physicians are usually still around the same level of compensation that you would see in other physicians. So we're going to move on to one last topic, which would be other compensation type issues to be aware of when looking at physician compensation. The first issue that we will speak to are issues to watch out for in connection with the sale or purchase of a physician practice. Specifically, these are types of arrangements that implicate federal and state healthcare fraud and abuse laws. The first type that we have on here is the idea of a retention payment, which would be paying a physician a certain amount of money if the physician remains employed after the sale of the physician's practice. So for example, if you sign a 3-year employment agreement with a physician after the practice is sold and the physician earns something like $200,000, if he is still employed at the end of the first year, $200,000 at the end of the second year, and $200,000 at the end of the third year. So it'd be a retention payment. Another type of arrangement is called an earn-out. An earn-out is an arrangement whereby in connection with the sale of the practice, there are metrics that can be met after the sale that would increase and trigger extra purchase price to the physician. And then also the idea of equity rollover. This could be where in connection with the purchase of the physician's practice, the physician is given equity in, as Erin mentioned previously, the management entity of a private equity investor or a holding company in order to incentivize and give that physician extra remuneration. And again, if you have any of these arrangements or anything that looks like these type of arrangements, you should consult a healthcare attorney. This can obviously implicate federal and state healthcare fraud and abuse laws. You can imagine there is at least the perception that these type of arrangements might be offering extra consideration or compensation to a potential referral source physician in order to get that physician to refer more to the practice going forward. Another item to be on the lookout for would be revenue that can be made through ancillary services. For example, we would commonly see an offer to a physician when trying to entice a physician to become employed of the ability to own in a physician group's ambulatory surgery center or vascular access center, or to also be able to have an ownership in any laboratory services that the group already has in place. Again, these are all areas that should definitely trigger a consultation with a healthcare attorney. There are all kinds of implications, again, with fraud and abuse, as well as other specific issues to these types of ancillary revenue sources that should be considered. And with that, we have reached the end of our presentation here in our session. Erin and I are open for comments. We are also available to receive comments via email afterwards. If something should pique your interest that you forgot to ask, feel free to reach out to both Erin and I. Do we have any questions or comments?
So we have a question that says, in an ophthalmology specific practice, what percentage of collections do physicians normally receive? Its typical attorney response is, it depends, but it really does. We've seen a lot of LOIs recently that are in brackets, honestly, that depends on the valuation of the practice, which will depend, the purchase price that a physician agrees on will implicate the percentage of collections, and it also incorporates different bonus mechanisms and just different ways that a physician seeks to get their money after the sale. And so in terms of what is normal, it's really difficult to say, but we're happy to discuss different valuation experts and third parties that can discuss, and we can obviously help structure any kind of physician employment agreement once the valuation has been complete. Chris, do you have anything else to add to that?
No, I think covered it pretty good.
Okay, great.
I like in the typical lawyer fashion, yes, it will depend. Also, we did want to mention that these slides will be available as well. Any other questions? And again, if you have anything that you remember later on, always feel free to let us know.
Yeah. We have another question that says, are you seeing any concierge models in specialties outside of primary care? If so, which ones?
Yeah, so this is an issue that we have actually recently been looking into. We have seen some in certain specialties. I feel like what I have seen is something in cardiac. However, so far it's mostly limited to primary care, which you can imagine why. It would be just because it is a model that leans itself towards primary care, the ability to just kind of perform your normal, your routine physical through the year, and then also be able to outsource and refer that person to another specialist. So the thing that we're still looking into and how it's developing is relationships between primary care physicians and specialists, and to see if there will actually be the development of relationships between primary care physicians and then specialist concierge physicians.
Yeah, I would say all the models I'm seeing really touch on primary care. A concierge primary care physician is a patient's quarterback through their healthcare journey, and that title usually only fits the primary care physician, but I agree with Chris that certain arrangements between the primary care physician and certain specialists, in order to have that, payment for quick service, attention to detail, and those aspects could be contracted with, but in terms of your quarterback, what you're going to pay a monthly fee for, I'm typically seeing it in the primary care aspect. The next question is, it appears that the seeds of a new MSO wave are being planted. What is different today? So I'm not sure I completely understand the question, but I guess there is a second wave of MSO, kind of a second wave of investment in terms of physician practices. So the first wave was in terms of dentistry, orthodontics, practice areas that really had a lot of commercial pay and self-pay patients. And then the wave happened in terms of practices that have an intersection between government pay as well as commercial pay and self-pay, for example, dermatology. And what I'm seeing now is that that first wave and second wave are complete in a sense, and that we're now going to experience a second wave of a private equity fund selling to another private equity fund instead of a practice, like a dermatology practice, selling to the first buyer of a private equity fund. And so I'm seeing that they're just getting a return on their investment, and we're going to keep seeing these waves of investments after efficiencies have been attained, and it's the right time. But it's all a timing process, and it's about different waves. But I say each different subsector has their own wave. I'm seeing kind of the first wave in women's health right now, whereas in dentistry and orthodontics and dermatology, I think we're experiencing a second and maybe even third wave. So if I didn't answer your question entirely, I'm happy to talk about this offline as well.
Okay. We have a question. At a high level, how are earnouts structured between a physician group and a private equity group to avoid fraud and abuse regulations? The short answer would be that we always advise to steer clear of an earnout. This is why there are other things that you can see that would be structured as retention bonuses. It's very difficult to structure an earnout in a way that does not trigger some kind of red flags, that you are actually trying to reward the selling physician who remains employed or could be a potential referral source. So if you are looking at an offer from a private equity group from the perspective of a physician or vice versa, and see the idea of an earnout or something that looks like an earnout, that would be a good time to ask a healthcare attorney and see if that's what you're looking for.
Yeah, I would say if there's federal or state reimbursement at play, an earnout needs to be really talked about and contemplated. And my first instinct, of course, as an attorney is not to just say no, but say what else can we do? And there's different models as a way to obtain those financials. But the word earnout, we're going to try to avoid at all times if that kind of reimbursement is at play at your practice. Yeah, so we have a question about the EBPC pool model and some of the complexities, issues in establishing this, and why it's still in an infancy and not more common. It's not that nothing has gone wrong. It's more that the MSOPC model at first started to become it started to target practices where the physician wanted to retire within 5 to 10 years. And now we're seeing that a private equity fund and a management company can offer something to the practice that any age physician is interested in, including just the idea that focusing their time on patients and they can focus their care efforts for patients and not the management of a practice. And so you're seeing this MSOPC model implemented in practices that have younger anchor physicians that have years of practice left in them. And so this EBPC model we're seeing truly at its infancy. I personally have only seen it at the LOI stage, and I maybe have seen one transaction actually incorporate it so far. But in a sense, it's to get those younger physicians active in the group and for add-on acquisitions. So you can picture it as like a pyramid, and you're going to have a hierarchy of physicians that get to split those earnings. However, whenever I talk about splitting earnings amongst physicians, especially in the federal and state reimbursement context, we need to be careful because you cannot, provide physicians any remuneration in terms of their volume or value of services. So that's when I said it has to be really carefully structured, and there are complexities that are really practice specific. I'll be honest, it's not a quick answer on this kind of webinar presentation. But in effect, it's a model that if you're a private equity fund, you need to start to understand because physicians are understanding it, and if there's a buying process, physicians are going to look for that in the LOI, and you just need to understand what it is at this point. Whether it's the right fit for your organization is something we can definitely talk about offline. But honestly, it's just a model that we want to start getting out into the area that it's happening and that it's being considered. And in terms of the complexities, I think I would say federal fraud and abuse are definitely at the top of that, but we're going to keep seeing that. We're going to see how the structuring works in terms of getting those positions started.
I think we have one last one here. So our question is, no matter the physician compensation plan, hospital system employed physicians typically do not break even and even lose money for hospitals. Do you have a feel as to whether health systems are divesting themselves of employed physicians as they did a decade ago? And if not, why? I have to admit, I would have to consult some of my colleagues about that a little bit more. I don't have a great answer to that one. I don't know if you do, Erin.
I don't think it's like we saw, you're right, like a decade ago when production was at its lowest, when we had that straight compensation model in the 1990s. I don't see that rush and worry amongst health systems and hospitals. However, I don't see employment of physicians as a younger physician as prevalent anymore. I think physicians are deciding to go to the practice route instead of being employed by a hospital. But we're in Chicago. I mean, we have a large academic centers here that are very attractive to physicians, and so I think we're a little biased on that end. But in terms of across the country, I agree with Chris. We would have to check with our colleagues who work with hospitals on a day-to-day basis to see what they're doing. But of course, we always see arrangements between smaller groups of physicians and hospitals, either with the PSA model or other models. And so the arrangements obviously are not going to cease, but whether direct employment is happening, I don't see this crazy crash, but I don't see it also being just a constant growth either. I feel like it's staying the same, but that's just my opinion. I'm not in the hospital system every single day either, so we'd have to consult our colleagues that are.
Yeah, I mean, I would say I have run into it less in my experience, but that would be just my particular experience.
Yeah. Well, I think we had some great questions, and I really appreciate that. We really appreciate that. So we'll send out our slides, and if there's any other questions from any of the participants, please feel free to call us or contact us, and we can even direct you to someone who can better answer your question if it's not us. But we really appreciate your time today. We have a series of these webinars that are occurring, and you can find it on the McGuireWoods website. We'll also include the link when we circulate the slides. And it's all about kind of physician alignment, strengthening that relationship, and we hope to see you at all of these. So thanks so much for your time today.
Thanks, everybody.